So the way the system is going to work is we've got handouts with slides and lots of detail. Obviously, this is going to be recorded and webcast for later use. So I'm going to be going over what I call highlights of these slides. I'm not going to walk through every slide and every little detail because there's about 60, 65 slides. I think I've got 45 minutes to do that. And I really want to use these slides to have you have powerful take-home messages for you, the people you work with, the patients you take care of. The hepatitis B world is pretty confusing to people. There's a lot of misconceptions about the disease and tests and how to interpret tests, so we're going to work on that. And actually I'm going to move to this slide next. I'm going to go forward one more slide for a moment, because this is really the base of testing and test interpretation. So hepatitis B infects, we think, about 240, 250 million people in the world today. And there's 2 billion people who have been exposed to hepatitis B. But I have a question for you. Is hepatitis B curable? It's a yes or no question.
Yes.
The answer is no. This is an incurable disease. So you need to carry that message to all of your patients, your providers, your colleagues, whoever you work with. Incurable. Hepatitis C is curable. We've got great new medications. Hepatitis A, never chronic. Hepatitis D piggybacks on B. We're not going to talk much about D today. Hepatitis E is like A, never chronic or almost never chronic. We have a great vaccine for hepatitis B, and that prevents primary infection. You prevent primary infection, you prevent chronicity. So we've got 3 tests we look for hepatitis B that every patient should have who has hepatitis B testing assessment. And here we have those 3 tests: surface antigen, core antibody, and surface antibody. Surface antigen is positive. That means current infection, currently infectious. Core antibody means exposure. So if you have core antibody positive and surface antigen negative, is that person infected? Again, this is a yes or no question.
Yes.
Seeing a lot of little head shakings going both ways. They are still infected. Once you have a disease that's incurable, and core antibody means exposure, that means you have hepatitis B in your body or in your patient's body the rest of their life. So hepatitis B is a DNA virus. We have other DNA viruses we're exposed to, like CMV, Epstein-Barr, herpes 1, herpes 2. You all heard of these viruses, right? They're all chronic. You get them. You have them the rest of your life. Although they may be inactive, they're still, you or your patients are still carrying that virus forward. Hepatitis B is the same story. It's an incurable disease, and if you've been exposed, your patient's been exposed, that person has hepatitis B forever. Now, surface antibody equals immunity only if the core antibody test is negative. So these 3 tests, these 3 concepts, you need to think about, write down, carry in your little phone or carry on a piece of paper, or have in your office. These are the correct current 2017 interpretations. So let's go back to that scenario. You've got a patient who's surface antigen negative, core antibody positive, surface antibody positive, and you give them chemotherapy. You give them an immune suppressant, prednisone, something for inflammatory bowel disease, something for lung disease, something for sarcoidosis, something for lupus. What is the risk for that patient? Right? Immune suppressed, they have the infection, reactivation. Everybody got that one? Next important step is hepatitis C, you're going to hear about today. We have great drugs for hepatitis C. They cure hepatitis C. You can give somebody with hepatitis C who also has hepatitis B a curative therapy for hepatitis C, and their hepatitis B can reactivate. This is a black box warning on all of the hepatitis C medications. So your job as a healthcare provider, a patient, or an advocate is to know these tests and to remind people what the tests mean. So if somebody has core antibody positive, surface antigen negative, surface antibody negative, what dose of hepatitis B vaccine do they need? Anybody? Anybody?
No vaccine.
How about none? No vaccine. People have been using booster doses of vaccine or enhancing their immunity with a vaccination. No benefit. Waste of money. All right? Any questions on this? I want to spend a lot of time on this slide. So I got 5 lines. But you have to have this foundation to understand the rest of the presentation. Make sense?
Yes.
Dr. Gish, the vaccine for hepatitis B doesn't give you a core antibody, is that correct?
That is correct. It's a surface antigen vaccine that gives you a surface antibody response. So if somebody's surface antibody positive only, they've been vaccinated and they're immune. Now, one interesting thing about the vaccine is that even if you don't get a surface antibody, it still protects. Because the vaccine is a B cell vaccine, which promotes antibody production, and it's a T cell vaccine, which stimulates a variety of different T cells that also can protect you. We just don't have a T cell test. I can't tell you what the T cell response is. But people who've gotten 3 doses of hepatitis B vaccine and have no antibody, in general, have high levels of protection. There's a couple of exceptions in the HIV community. If you're immune suppressed, you get 3 doses of vaccine, you may not be protected. But in general, the vaccine affects both arms of the immune system and provides protection. So we don't boost people even if they don't have surface antibody, because we feel that they're protected. Very interesting issue. Any other questions on this? All right, I'm going to go back 1 slide, which is the very first slide. So if I have a patient that's surface antigen positive, I work here in San Diego at La Maestra. I work for Stanford. We have 7 clinics that I run in Northern California, Nevada. And I see a lot of hepatitis B every week, every month. And this is what I do basically on all of my hepatitis B patients, although I don't do liver biopsy on very many people, but it's listed there. And almost everything else here I'm going to do. This is a little bit expensive here. It's a blood test for fibrosis. I may not do that. We're going to talk about family testing. So a woman of childbearing age. We're going to talk about pregnancy. We're going to check for HIV, hepatitis C, and Delta. APRI and FIB4, which is on the right side, are minimally invasive tests. Or basically you get a blood draw, look at liver enzymes, you look at platelet count, and you can assess the severity of their liver disease. You want to know the stage of liver disease in every hepatitis B patient. Spleen size and portal vein diameter, upper right-hand corner. That's determined by ultrasound. So every patient with hepatitis B gets a full abdominal ultrasound. You want to see what the portal vein looks like. Is it open? Do they have liver cancer? That ultrasound will tell you a lot about whether they have cirrhosis or not because of the liver configuration. And the spleen is big, the portal vein is big, they probably have advanced liver disease. Now on this slide, there is one test. It's the simplest test to look at or infer the level of liver damage that a patient has. There's another question. What test on this slide, it's almost free, is highly accurate? Say it louder. ALT is not so good at staging disease. ALT helps determine level of liver inflammation, and liver inflammation relates to how the immune response is seeing the virus. But the ALT doesn't tell you today how bad their liver is. What other test on here? Anybody else? Platelets is the answer. It's almost free, right? You're getting a CDC on all of your patients, right? And that's the on-off button, and that's the pointer. Okay. So platelet count. is related to what other tests on this slide? What does the platelet count tell you when it's low? Anybody? It's going to tell you how big the spleen is. The spleen gets big, platelets go low. So the platelet count is proportional to the spleen size. Okay? When the spleen is big, that means the liver has advanced fibrosis or cirrhosis. So a platelet count under 170,000 in a hepatitis B patient indicates advanced fibrosis, and once it's under 100,000, it indicates cirrhosis. This is highly accurate, meaning you're going to be able to look at the platelet count, and 8 out of 10, maybe 9 out of 10 hepatitis B patients, and tell you that patient how bad their liver is off one test that's already in the chart. It's clear to everybody? Incredibly cheap, useful, powerful test. You can use it in hepatitis C, and you can use it in fatty liver, a lot of other diseases. But there's a lot of other things that we do for our patients. These are blood tests, the AFP, AFPL3, and DCP. Those are blood tests that determine future liver cancer risk. They are FDA approved, FDA cleared. This is my recommendation. Not everybody does all 3 of these tests, but they are moving forward and will be much more mainstream in the next 2 years because there's a lot of emerging data about those and how useful they are. Back to the ALT. Is that your favorite liver function test? Beware of trick questions, because an ALT is not a liver function test, it's a liver enzyme. A lot of providers call them liver function tests, but the ALT and AST have nothing to do with liver function. So it's bad or wrong terminology to call that a liver function test. Liver function tests are bilirubin, albumin, and a clotting test called an INR. That will tell you the patient's liver function. ALT just tells you the level of inflammation. So it's very important with ALT to know what is normal, what is healthy. So a woman who's got normal body weight, drinks minimal or no alcohol, is not on any medications, not on any herbs, doesn't have diabetes, what should a woman's ALT be to indicate liver health? What number? Under 20. Men ALT should be under 30. This is true for fatty liver, hepatitis C, autoimmune. This is a healthy ALT level across all disease states. That's the target. If your ALT is over 20 and you're a woman, there's something wrong. If it's over 30 and you're a man, there's something wrong. And that needs to be figured out, calculated, and an intervention. Another very useful test on here for all of our hepatitis B patients is the DNA level. That's the level of virus in the blood, which relates to how much is in the liver, which relates to risk for cirrhosis and cancer. So now we're integrating a platelet count, scan, DNA level, ALT, liver cancer biomarkers, and we're going to build a much bigger picture about that patient's current liver status and then their risk in the next 5 years for bad outcomes: cirrhosis, liver failure, death, transplant, cancer. It's not very complicated. If you want to do all of these tests, you'll spend a few $100s putting this together. But you can have a very clear roadmap on how to manage that hepatitis B patient after putting this together. And this is what we do every day. Christine's on the left, who works with me at La Maestra. We've got a team there. Christian Ramers, you'll hear from a little bit later this morning. He's got a very similar protocol at family health centers. This is what happens at UCSD or Scripps or Sharp or Kaiser also. This is standard profiling of a hepatitis B patient. So I'm going to stop for a minute. I'm going to move very quickly through a lot of the rest of the slides, but these are base facts that you just need to know about everybody, where we start with hepatitis B. Any questions on this, if you want your voice recorded? Go ahead.
I have a question. So we work for public health department, we review a lot of positives, hepatitis B, hepatitis D. My question, lately we've been seeing a lot of HDV positives on the patients who are also hepatitis B surface antigen positive.
So delta test, you're saying?
Correct.
Right.
So delta testing. Does it mean that this patient, particular patient, also had HDV, or it's a cross reaction?
That is a highly specific test, meaning false positives are extremely rare. So a delta antibody test that's positive means either current delta or historical delta, meaning delta is curable. It's low rate of cure, but it's an RNA virus. The delta antibody means immediate workup, advanced testing, and to see a liver specialist.
With that said, if the patient already being seen, most of the time those tests,
Or ordered by a liver
are
specialist.
ordered by liver specialists.
Right.
So if this particular patient is positive for HDV antibodies, correct, but also known and been reported to public health department as chronic hepatitis B carrier, does that mean that this particular patient has both?
Yes.
Okay, so that was my question.
To prove that their delta is active, then you have to reflex after the antibody test to a delta RNA test.
Okay.
There's two ways to get that done. Public health department can send the blood to the CDC, got to fill out some forms. And if you also want to get it done commercially, you can send it to ARUP in Salt Lake City. There's less forms. But if you send it to the CDC, it goes into a database. It's quite useful. So I think either way is fine, but that delta antibody test means a reflex to an RNA test.
Got it.
You want to know the level of virus. Hepatitis C antibody, you get an RNA test. Hepatitis B and surface antigen positive, you get a DNA test, DNA quant. Great question. And any of those delta patients definitely have to be educated, linked to care, followed up. Their risk of cirrhosis, 70%. Very, very high risk. There are some patients that clear hepatitis delta spontaneously and they're cured. All right, let's move forward. We're going to move a little bit faster. I think we've covered most of this, so I'm going to move quickly and talk about prevalence. High prevalence, medium prevalence, low prevalence. But U.S. is a low prevalence country, but we're here to talk about hepatitis B because this has a high prevalence in a lot of our special immigrant population. 70% of our hepatitis B in the United States right now is an immigrant population. So any place you have a clinic that takes care of immigrants, hepatitis B testing needs to be performed on any person who's a first generation, meaning they were born outside the U.S., second generation, if their family came from a high prevalence region. Automatic testing. We've been trying to talk about making sure every person who comes into the U.S. gets tested at the time point of immigration. There are some issues with that because of fear of discrimination, they don't have health insurance. But if you've got a disease, you need to know about the disease. Even if you don't have health insurance, you can tell them, lose weight, don't drink alcohol, that's free, right? You're infectious, that's free. Right? So testing as early as possible as people enter the U.S. and the healthcare system is very important. Love this slide. I'm not going to spend much time on this slide. I could spend 1 hour talking about this slide. This is how complicated hepatitis B is in terms of its interaction with the immune system. The virus is mutating, it's changing. It goes from active to inactive, high replication with minimal activity. This has to do with how the virus matures over time and how the patient's immune system matures over time. But the simple take-home message from this slide is you need to know the ALT and DNA on every patient, and then by just combining the DNA and ALT and their age, duration of disease, and then you're going to put one more test on top of that, that's called the E antigen, you can figure out where they are in this disease state. Typically right now, to decide to treat somebody, very simple rule, DNA over 2,000 for the hepatitis B, ALT elevated, we just said what elevated was, 20 and 30. That person should have counseling about treatment. Those two things. I'm not saying all of those patients have to go on treatment, but I'm very likely to treat anybody that fits those two. ALT in a man over 30 and a DNA that's 3,000, I'm quite likely to treat. Now, if the DNA is 10 million, I'm even more likely to treat. So there's a little bit of a gradient depending on the test results. So ALT, DNA, E antigen status is going to allow you to integrate all this information and determine what phase of disease they're in. This just walks you through risk. So when you see a hepatitis B patient, you're going to look them in the eye and say, if you're a man, you have a 30 to 40% lifetime risk of cirrhosis, cancer, transplant, or death. If you're a woman, you have a 15 to 20% lifetime risk of cirrhosis, cancer, transplant, or death. If you give that simple message to somebody who's surface antigen positive, they're more likely to come back and get medical care. They know they have a serious disease with potentially very serious outcomes. You've got to deliver that message. There is no healthy carrier. There's no healthy hepatitis B patient. Now, they may be asymptomatic, but that doesn't mean they don't need follow-up. Oh, I feel fine, you look fine, your liver tests aren't that bad, we'll see you in 5 years. That's wrong. These people should be seen every 6 months by somebody who has an interest in, training in, or is an expert in managing hepatitis B. And keep them engaged, because they may move from one phase to a different phase and need treatment. They may develop a liver cancer, they may be at risk for cancer, so they need more frequent testing. Then you can talk about transplant, death, reactivation, which we talked about, all that's contained on this slide. It's been a major miracle to have hepatitis B vaccination available in the US. So in the US, in the population that's not an immigrant population, gotten vaccinated, we're seeing a huge decline in hepatitis B. So you're really seeing this as an adult disease or adult-acquired disease. You're not seeing this in American-born children, except about 1,000 kids are missed by the vaccination or vaccination H-big protocol. And the, I call it HRSA, Medicare, Medicaid programs want to get that number from 1,000 down to 10. So there's a major effort now to break that maternal-fetal transmission process that takes place. Now, what's happened in 2017, the slide only goes up to 2008, so it looks very, very cheerful. We have an outbreak of IV drug use in the United States. It has to do with changes in regulation with narcotic access and how cheap narcotics are, like heroin or synthetic things that are coming in from China. Very, very cheap. So if you want to be an OxyContin addict, it's $100 to $150 a day to maintain if you can even find the drug anywhere. If you want to be a heroin addict, it's $25 a day. But there's an issue of needles and sharing equipment. So we're having this outbreak of hepatitis C, that's PWID, people with injection drug use related, and hepatitis B, there's an outbreak as well. So you have immigrants, we have IV drug use, and then low levels of sexual transmission, low levels of maternal-fetal transmission. All right, 2 million people we think is the number in the US right now, and the death rate, 2,000 to 4,000 deaths per year. We think that's an underestimate, but that number is relatively low because since 2005, we've had fantastic treatment for hepatitis B, with entecavir released in 2005 and then tenofovir in 2008. If you're on these drugs continuously and you're compliant, your patient's compliant, the patient's going to have undetectable virus, and it's very rare they'll get liver failure. I'm not going to say very rare, I'm just going to say rare that they're going to get liver cancer. So we've got great medications to suppress virus, slow disease, reverse disease, prevent transplant, even prevent death.
Dr. Gish, how long does it take to become undetectable with hepatitis B?
2 to 3 years on treatment.
2 to 3 years.
The delta, the change over time. But you can get 50 to 60% negative in the first year, 60 to 70% negative by the second year, 80 to 90% negative by the third year. And if you're compliant, your patient's compliant, by the 5th year, E antigen negative, it's about 99% or undetectable. E antigen positive, about 90% are undetectable. So occasionally we have to add a second drug or switch drugs to get everybody undetectable. The goal is no DNA virus in the blood. This just has to do with foreign-born patients and where they've come from, and the people who are surface antigen positive or inferred by these numbers. We have 41 million foreign-born people in the U.S. because we're a country of immigrants, right? Almost all immigrants. Yes?
I want to jump ahead, but when you made the last announcement as relates to after 5 years, what is the cost?
All right, so the cost of tenofovir, I think, is about $15 a pill right now, retail. Insurance companies have various different contracts. So let's say it's $10 a pill, so that's $300 a month, that's $4,000 a year. At 10 years, you've spent $40,000. So that's pretty cheap, actually. What's the average lifetime treatment cost for an HIV patient? It's almost $500,000, and you're not curing anybody, right? The $500,000 is the average lifetime cost of taking care of an HIV patient. Now, HIV patients are living a very long time, so that numbers can't be perfectly accurate because their care goes on and on and on. But you're just mixing people who are dying in car accidents or rarely of HIV or a cancer or whatever, and then you're looking across average lifetime costs, $500,000. So when everybody's complaining about the hepatitis C drugs costing $90,000 with a 95% cure rate, I thought that complaint was the biggest joke in the world. Because we're spending 10 times that or 5 times that taking care of HIV patients and not curing a single one. And nobody's complaining about that number. So why are they complaining about hepatitis C when we're curing almost everybody? Because it's political, it's discrimination. There's all sorts of bizarre things that happen in our country around disease and disease management. So hepatitis B, we're not curing anybody, but we are taking the death rate, transplant rate, disability rate, infection rate down very, very, very low. It's just another part of the miracle. I mean, in 2000, I used to see patients come in every month with liver failure from hepatitis B. I've referred one patient for liver failure to Stanford in the last 3 years for hepatitis B. That's a Lao woman who was given entecavir at a higher dose and was sick to her stomach, and she didn't like taking it, so she went on and off her entecavir. It just got worse and worse and worse. Every time she went off, she had a flare, and she developed ascites and liver failure, and then we got her back on her entecavir. I just saw her in Fresno the day before yesterday, and her bilirubin went from 30 down to 4, and her albumin went from 2.6 up to 3.6. And her ascites, though, is still present, so she's going to get listed for transplant, but she may not need a transplant for quite a while, and she might even get better. We'll see. So compliance is really important. This is a non-compliant patient. That's why she got referred for transplant. It's not that the drug wasn't working. All right, let's keep moving through here. How much time do I have, Scott?
15 minutes.
15 minutes, right. So we have another 50 slides to go through. We're going to move quite quickly, so I'm just going to hit high points on these slides. This just has to do with geographical issues in North America and Western Europe. Sexual transmission is a lot higher risk for acute/chronic disease. But again, it's really an immigrant issue in the United States. But if you get adult-acquired hepatitis B, chronic disease, meaning surface antigen positive, is rare because as an adult, you get a better immune response. You can clear things a little bit better. Genotyping, I try to do on all my hepatitis B patients. It's a very complicated story. I'm not going to go into it because some genotypes are worse than others, but it's really a second-line test, not required. I'm going to call it useful, but not required. And there's some different genotypes in different parts of the U.S. It has to do with their ethnicity, how they acquired hepatitis B, what part of the world they're from. And this, again, just talks about different variants. For instance, genotype A responds to interferon better, but we don't even use interferon in the U.S., so it's a low relevance. All right, this just has to do with knowledge, testing, linking to care. There's all sorts of different programs going on with the CDC, Hepatitis B Task Force, Hepatitis B Foundation, Hepatitis B United. We're trying to get up to identifying all 2 million people. There are projects in place to help make that happen. This just talks about the small number of patients that are linked to care. So you've got 2 million people that have hepatitis B and you only have 100,000 on treatment at any time. So we have a major gap, and we're going to be working on that. Lack of knowledge, lack of education, you all are part of helping to fix that problem. That's why you're here today. Screening is key. We really want the primary care providers to be doing screening. We want screening, hopefully in the next 3 years, in the pharmacy setting, right? Come to the pharmacy, get screened for hypertension, get screened for diabetes, get screened for hepatitis B and C, whatever the risk factors are, those algorithms will be in place. So pharmacies are really going to move forward as major locations in addition to the primary care clinic for testing. This will help improve morbidity and mortality, reverse progression of liver disease, and they'll get patients into liver cancer surveillance at an earlier time. Look at this long list of people who need hepatitis B testing. So basically, if you even think about hepatitis B testing, you're at risk, right? Blood exposure, immigration, elevated enzymes. 3 very, very simple questions. This has to do with hepatitis B having an effect on pregnancy. So there's linkages during pregnancy with higher preterm birth, lower birth weight, gestational diabetes, preeclampsia. These are all issues that hepatitis B is looked at as a systemic disease. It's not just a viral disease that infects the liver, but it affects the health of that patient, that mother, in a situation of pregnancy. So even if somebody tells you they've been vaccinated, they need to have a full hepatitis B panel in their chart. Because sometimes people get vaccinated without hepatitis B testing, and then they think they're protected when they're infected. So make sure you've got a full hepatitis B panel in every patient, regardless of their vaccine status. And then this just talks about the different tests we've already gone over. And then this has to do with correlation between other risk behavior in terms of chronically infected with hepatitis B, and then ever infected, meaning core antibody positive. So if you look at a hepatitis C population in the US that's going on hepatitis C treatment, you're going to find core antibody in 60% of hepatitis C patients. Because when they're exposed to blood, which is how they got hepatitis C, they're at risk for having hepatitis B currently, or exposure historically, meaning core antibody. Look at all these areas of the world with a surface antigen prevalence of over 2%. Most of the world, right? We're missing the US and Canada, although parts of Canada may have a higher prevalence, parts of Western Europe, but basically, if someone's an immigrant, they get hepatitis B testing. We talked about what the tests are, what those tests mean. This is just a repeat on that. And then this talks about the different tests. The only point on this slide I want to make is that we've been working at La Maestra to get this changed. So when you order a hepatitis panel, the lab almost always is ordering an acute panel. You don't need an acute panel, you need a chronic panel. So we're changing the EMR ordering system in NextGen at La Maestra, so you don't get this IgM core antibody on patients who you think have chronic disease. The only implication there is acute disease. So you do an acute panel if they're yellow and their enzymes are 300, but everybody else gets what's called a chronic panel, and that's really different. I've already described what those tests are, and that's on this slide, except we're going to take that core IgM test off of that if we think they have chronic disease. This is a table that talks about how to interpret these tests. We've already gone over this. I just want to show you this so maybe you can print this out or keep this handy. And also recommending testing. Now this is off the CDC website. It's ridiculously complicated. I want the CDC to say, you think you have hepatitis B, do these 3 tests, and you're done. It's not that much more money. And because they have all these different risk groups and different tests they're talking about, the right tests don't get done. Or they get an acute panel. And then someone doesn't really understand the acute panel, doesn't order the chronic panel, and then we have all these missing tests. So I'm working on the CDC to get this done and get this changed. And we've talked about how you stratify patients with e-antigen, DNA and ALT to decide what phase they're in. There is something called occult hepatitis B. Surface antigen's gone, core antibodies positive. You can measure viral DNA, find the virus in the blood, even though the surface antigen is negative, in about 7 out of 100 patients, maybe 10 out of 100 patients. What do you do with those people? You got DNA that's measurable, they've got virus in their blood. You have to send those people, in my opinion, to a liver specialist, and then that person can counsel them on what to do next. Maybe a higher risk of reactivation, maybe they will have active liver disease, so it has to be looked at especially. So occult's a very, very special population that we think about. These are all the different commercial tests for looking at the level of DNA. Don't worry about this slide in the sense as you order a DNA quant, you're going to get a high quality test, you're going to get an accurate result. We talk about maternal-fetal, maternal-child transmission. One key issue on this slide is that the baby can actually be infected in utero before birth. So there's, in the uterus, there's birth canal, and then there's transmission after birth, but usually intrauterine, maybe 20%, 80% in the birth canal during the birthing process. So if we give a mother, if we don't give any treatment to the baby at birth, which is vaccine and HBIG, we have a transmission rate that varies from 12 to 90%, depending on the mother's status. So the two things in the mom we want to know, so their E antigen and their DNA level. And DNA in the mother over 200,000 indicates the threshold for risk transmission to the baby, where the baby needs HBIG, even more importantly, but even more important than that is the mother gets tenofovir during the last trimester. So 200,000 is the trigger to make sure the baby's getting vaccinated, baby's getting HBIG compulsively, and the mom gets for 3 months a nuke to suppress virus. These are all the different reasons that hepatitis B can be transmitted, but they all have to do with blood exposure, the birthing process that takes place. I'm not going to read through all of these issues, but we do have ways to take that transmission rate. Three steps. Moms need it to get tenofovir, vaccine, and HBIG, and we can take that transmission rate down to less than 1% with applications of those 3 steps where appropriate. It's the DNA level that's key in the mom that talks about that. That 200,000 is your take-home message today. So this is basically talking about persistent HBV infection, and why E antigen status is important is when the E antigen is positive, that indicates that the mother has what's called a wild type virus, the virus before it's mutated into a pre-core mutant. We've got some special names. That E antigen indicates that the mother is much more infectious to the baby. That wild type virus is much more likely to be transmitted to the baby. It's more infectious, more likely to be chronic. So, this is a complicated slide, but it basically goes back to the DNA issue. So I'm going to move through this quickly. Tenofovir is very, very safe during pregnancy. We really have a few educational events for the mom, but the risk to the mother or the baby is very, very low. And this is definitely standard of care for the mother if the mother has a viral load of over 200,000. That's the number. They looked at tenofovir versus no treatment. This actually is a randomized trial that was published. We actually consented and got this whole process done. And you can see that in the babies where the mother got tenofovir here versus no treatment, this is per protocol. It means if they stuck with all the different steps, tenofovir took the transmission risk down to 0. Now the right side is they didn't follow all the protocol steps. They weren't perfect about HBIG or vaccine or starting the tenofovir correctly or finishing the tenofovir. You're still taking the risk of transmission from about 20% down to 5%, which is amazing. Per protocol, compliance, we're good. Scott, how many more minutes? 5 minutes, okay. I'm going to move relatively quickly. You're pretty close though to being done. Vaccine, vaccine, vaccine after you have hepatitis B panel, right? Vaccination at the time of testing can be done before you get the hepatitis B test results back, because maybe you're going to lose the patient to follow-up. But that vaccine, that first dose, could be considered a waste of time, because if they already have hepatitis B surface antigen, it's going to be worthless. If they're core antibody positive, it's going to be worthless. That's the problem. You've got to make sure that test is done and the test is linked to care. Trends in vaccination, we're doing pretty well. Green is up to 2006, blue is up to 2010. So we are getting better in all these different groups. So not perfect yet, but we're getting close. And this is a national cohort of veterans of how, I would say, mediocre the hepatitis B care is in the VA. And the VA is trying to get better. They've done a great job with hepatitis C testing and linkage to care and cure. Hepatitis C in the veteran population is going to be a relatively rare disease, and it's going to be a disease mostly in non-compliant patients who aren't getting regular follow-up in the VA. But there are a lot of gaps in the hepatitis B world in the VA that's being worked on. Hawaii's been at the cutting edge of treating and screening, so there's some slides in here about how Hawaii's been successful in its money, and its time, and its advocacy, and its policy, governmental interventions that are all present.